So welcome to Reclaim Your Movement Town Hall. During this town hall, all participants will be able to turn their mic on. So it's important that when you're not speaking that you mute your mic. This event is being recorded, and if you don't want your video and or your name in the recording, send questions through the chat feature, and you can change your name by going to the participant list and clicking the drop-down menu for, and it'll say rename. And so there will be a brief background session where Jean will talk about some more information. However, this is intended to be an interactive session guided by your questions. So join me, and I want to see some faces. Please remember the information provided in this web event is not intended as a substitute for your physician's guidance and care. My name is Sydney Stern, and I'm the Director of Giant Cell Tumor Programs, and I am your moderator for today. Lauren Wilder, a TGCT volunteer, is going to be moderating the chat to make sure no one's questions get lost. We would like to thank our sponsors for today's event, Daiichi Sankyo and Decipher Pharmaceutical. Now I would like to introduce our guest today. Jean, I'm sorry, I don't know how to say your last name, but Jean is a doctor of physical therapy with a degree from University of Maryland School of Medicine. He has extensive experience in orthopedics, pain science, and sports medicine. His professional career ranges from clinical practice to entrepreneurial endeavors, such as inventing a neck pain device, auditioning for Shark Tank, and founding a modern health business. He currently owns and operates a unique health facility that combines physical therapy and fitness called Recharge. And so, Jean, I will let you take it away.
Thanks, Sid. First of all, I am not proceeding with this presentation until you attempt my last name. So I'm just going to sit here quietly until I hear you try it.
Shirokabra?
That's pretty good. That's pretty good. Good job, Shirakabrad. It's very phonetic. You just go along. It's very, very simple. Thank you. Sid asked me to participate, and I'm always thrilled to speak about complex topics, because this is certainly a complex topic. I'm pretty sure every single answer I could give you is it depends. And I feel like those are the most important conversations to have because they have the most relevance to day-to-day practice. Most clinical things are it depends. There's certainly very little certainty in most things. So when there is less certainty, there is more ambiguity, and there's always there's this aura of now what. So today, what I would really like to do is establish some foundational and conceptual frameworks with you, and then really go over your questions, right? Because I can certainly present and give you information, but if I had to bet a nickel, I'm guessing that most of you are very good researchers and have a very good understanding of most of this information. So what I would like to create some practicality between situations and questions. So with that said, as most things, they start with mindset and concepts. Movement is no different, or the science and the medicine of movement. For us, the motto that we follow is movement is medicine. And as with any medicine, for it to be effective, you have to understand dosage, right? You wouldn't just take an arbitrary amount of medicine, whether prescribed or over the counter, without knowing exactly which dosage to take. Movement is very, very much the same. Movement is a combination that affects anything from hormones to stress levels, to obviously tissue quality and texture. So a host of changes happen with movement. So if you understand the dosage and how to effectively prescribe that dosage to various scenarios, various individuals, and various goals, then it becomes very, very effective. And we have about as much research on the positive effects of movement as anything else, because those studies are fairly easy to do. So effective movement is great, but is there an opposite, right? In as we know that every there's an opposite to everything. So is there a negative to movement? Of course, the answer is yes. There certainly is. But for most people, the positives greatly outweigh the negatives with movement. But what happens once in a while is we tend to vilify movement. And usually we vilify movement based on a perception or a negative connotation to an ailment or some kind of pain or dysfunction that we have. So if we have pain in the hip, all of a sudden that becomes our bad hip. And here are the bad movements that my hip can't do because it hurts. Um, has anybody ever had that thought that this is my bad fill in the blank, or this is a bad movement, this is a no movement for me? Yeah, yeah. You're not the only ones. It happens all the time. But the reality is there really is no such thing as bad movement. There is no such thing as good movement. There is only movement. And our qualifications of good or bad are dependent on our scenarios and our framing of what we're trying to accomplish. And it's usually biased by pain or our fear of what can potentially happen due to this movement. So for me, and when we're working with our members or anybody else, it's first of all laying that groundwork of you need to move away from good and bad. You need to establish movement is what it is. It's movement. Then it's about dosage. Then it's about appropriately understanding how movement will affect you, and it becomes a cause and effect scenario. So there is no good or bad. There is only movement. We do not vilify movement. This is one of the big take homes I would like for you to process. So please hear me. There is no vilification of movement. There is no good or bad. There is only movement. And if you can appropriately dose it to your scenario, then it becomes an incredibly effective way to get to an end goal that you have to establish. So the second part of that is the end goal that you have to establish. Um, there is a saying that I'm very fond of, and that is, if it doesn't get measured, it doesn't matter. So you have to measure what matters. So you have to establish goals for movement. If you're moving as part of rehab, there needs to be goals. If you're moving in terms of performance, there has to be goals. There always has to be a clear purpose for the movement that you're trying to get or trying to do. When you make movement purposeful and you combine it in a pattern, that becomes exercise. And then once you do that with purpose over time, that becomes training. So you have to again tell and frame it for yourself of what are you trying to do with movement. Is it movement for the sake of movement? Is it movement for the sake of exercise? And then once you put exercise together for a clear purpose, then it becomes training. And you never arbitrarily train, you're always training for a reason and a goal. So when you're rehabbing from surgery or you're rehabbing from um, whatever the issue is that you're trying to move past, there always has to be clear goals. And by setting those goals, you don't give yourself the ability to vilify movement because there's always a purpose and a clear strategy for each of those movements, right? You wouldn't do a bad movement because it would be part of your programming. Therefore, it's not even in your lexicon to say it. And that's a very important, powerful framework for people, right? That's an empowering thing to say that there's always movement for me. There's always a strategy for me, and then it's adapting it over time because there has to be adaptability. Your body goes through adaptability, therefore you have to adjust accordingly with movement. So there's a lot obviously that goes into it. I'm sure you have a lot of questions as well, and I really want to get to those questions. The final piece I'll say for me, it's always about progress. There's always progress. And progress is a combination. It's always a combination between push and rest. You have to understand that formula, that progress happens when you push in an appropriate way, but you also have to rest in appropriate way. And this is so hard for many, that the feeling of stopping or resting or slowing down or changing often feels like it's a step backwards, but it's not. You have to push and you have to rest at various times in order to continually progress and move forward. We don't live in a vacuum. Movement doesn't happen in a vacuum. Healing doesn't happen in a vacuum. Textbooks give us guidelines. Medicine is about pattern recognition. We do our best to recognize the patterns from a larger sample size of conditions, similar conditions. But even that, those are guiding patterns to help us adjust, and never ever in a vacuum, especially with movement. So that's my overview, my little soapbox spiel on movement. There's a lot that goes into it, so I will let Sid moderate. I'll take the questions that you have, and then we'll finish out.
Okay, if someone would like to unmute their mic and ask a question, otherwise you can type it in the chat as well. Okay, I'll start off with people who have sent it previously. So a patient had discussed or had sent in that they were told not to run or even jog or do squats post-op, and that would likely be a permanent change in their lifestyle, is not high impact movement after their major operation, and that it may cause like some sort of internal damage. Even though she really likes doing it and she does not want to train for a marathon, she's asking how can she push for goals like walking 4 to 5 miles.
That's that's a great question, and that's a tough scenario to be in. Um, we've helped a lot of people that have been told you will never, and then fill in the blank X, Y, and Z. Um, I think that's it shouldn't happen unless it's a certain certainty, and that even that hardly ever happens. Again, I don't know this specific case. I'm talking in my experience and overall, often common scenarios. That there is more times than not a path towards return to some level of it's called high impact activity. Certainly not always, of course. There's always those end results, but we tend to look at things on the bell curve of standard deviations, right? We have the end ranges, but we also have that middle section where the majority happens. Running is very tough. I could see if that person asked their physician, "Will I run again?" And based on that snapshot in time, their answer was, based on what I'm seeing now, no. I could see that. Is that the right answer? I don't think so. The answer should always be, it's too early to tell right now. If it is possible, here are the steps you need to take. Um, I tend to think in possibilities and probabilities. Most of us tend to think in possibilities when there's an unknown. When an unknown exists, our brain goes to those end ranges of what's possible. Is it possible to feast, or is it possible to famine? Whereas the question should be, what is probable? What is most likely to happen, not what could happen or potentially will happen. So the probability is that the body is very resilient and capable of progressing to dynamic activity. The question you have to answer is, can it? How does it? So the answer to that question, it's what's called cumulative and progressive loading. So if somebody wants to run, they have to jog. If somebody wants to jog, they have to walk quickly. If somebody wants to walk quickly, they have to walk fast. If somebody wants to walk fast, they have to walk slow. So there's a progression of load. And then you have to understand, when you start in that slowest progression, right? If somebody starts post-surgical with limping and dealing with post-surgical pain, they have an antalgic gait. They have a painful, adjusted, compensated gait. So there's no jogging, there's no even walking until the gait is worked through, until post-surgical pain is gone, until tissue healing happens. And then you start to add that next layer of challenge by making them say, okay, our next goal, again, setting goals, is for you to walk 100 feet without a limp, or without your hip kicking out, or without your heart rate jumping up to 105 beats per minute when resting is 60. So it's establishing these objective markers. And then once those markers are met consistently for a period, then you add the next progressive load, right? Then you add a faster walk and so forth. And then you can say with much more certainty, yes or no to something like that with a run. But to give somebody an answer post-op very quickly is a bit unfair.
Is there conditions in which would make running or jogging or even high intensity walking harder, like doing it on concrete versus grass, and different shoes and support systems that you can to make it more feasible?
That's a great question. I call them secondary environmental factors, right? The primary factor are always factors that you have the most locus of control over, which is yourself and your body. So if you can get past that first layer of a controlled environment and dealing with your primary factors like your tissue healing and your progressing, then you could certainly look at other aspects of running, like running outside. Concrete obviously is going to be a little bit less friendly. You have what's called ground reaction forces, right? The opposite and equal again. So every time you run and your heel hits the ground, you have the opposite and equal force come right back at you, called ground reaction forces. So this obviously takes understanding joint mechanics and potential tissue involvement, because your body has to dissipate that force that comes back at it. And technique certainly helps, but that force goes through your bones, goes through your joints, and then your tissues, like your muscles, absorb those forces more than anything, because they're bigger and they have more surface area and they're softer. So all of those play a role in determining that.
All right, so we just had a question come in through the chat. It is, how do you know when pain or discomfort is a sign to stop versus something you can get past because you're rebuilding your strength and range of motion?
Oh, that is the $1,000,000 question. Pain. Is pain good or is pain bad? My favorite thing is always answer questions with more questions, and then just keep asking questions until people forget what the initial question was. And then I can just ask the question again my way. How do you know if pain is good or bad? I think that essentially boils down to, first let's understand pain. Let's talk about it. I'm going to give you a pain medicine or pain science breakdown in 2 minutes. So a reductionist distillation of pain, 10 years of pain science in 2 minutes. Ready? Here we go. Pain is danger. Pain is a danger process. Most people think of pain as cause and effect. Something bad is happening, something got disrupted. I tore a ligament, a muscle, something happened, therefore I have pain. People think in terms of pain thresholds. I have a high pain threshold, or I have a low pain threshold. The reality is pain is a danger signal in a lot of instances. Now, this is pain without a clear cause. So if you just had surgery, your tissue was disrupted, your nerve fibers are trying to communicate, but they're not fully connected on the pathway. So your brain is sending signals and your nerves are trying to connect and telling your brain something is going on here. And then every time you try to move and the tissue moves there, it sends a greater signal to your brain saying that tissue is disrupted. Therefore, it's painful because there's more danger. The tissue is not together. There's a lot of danger there. right? The paths are not clear. But pain that doesn't have a clear-cut pathway or a clear-cut answer is still a danger processing. It's your check engine light in your car, right? If you're driving all of a sudden, think of it this way. If you're driving all of a sudden in your neighborhood and you have your check engine light on, how worried are you? Probably not that much. Annoyed? Probably, but you're like, oh, I'm close to home. I don't feel that bad. What if you are traveling for business in a completely different city and you have no idea where you want and your rental car all of a sudden gets a check engine light? How concerned are you then? Probably significantly more. It's the same check engine light in a very different scenario. So pain has so much to do not just with your body and your tissues, but also with your environment, your societal surroundings, but also your perception and your fear of it, which is psychological. So the model that most of us look at, it's called biopsychosocial. So your biology, your psychology, and your sociology play a role within pain. So how do you know if pain is good or bad? First, you have to ask yourself, what is happening with me right now? How stressed am I? Have I been getting poor sleep? Do I have a good support system? Do I have an environment to deal with everything that I'm dealing with now? Which is a big deal when you are in chronic pain or when you are in sustained pain. When you're in pain, to come back to the question of if I'm doing activity, how do I know that it's okay for me to sustain this activity with this level of discomfort that I'm feeling? And the answer to that is similar to what I said before. You have to establish some markers, some objective measures for yourself. So one of the ways to do that is utilize a pain scale that I'm not a big fan of, but it serves a purpose in this regard, right? Most of you have seen or have heard of the visual analog scale, which is the 0 to 10 pain scale, right? I'm sure most of you, if not all of you, have at some point been asked, what is your pain? Um, and we typically create the structure for our members is that you have the red light, yellow light, green light. So green light is if you're somewhere in that 0 to 3 or 4 discomfort range, that's green light. You can still move through that and you can still do your activities. If you're in that 4 to 7 range, that's yellow light. You can still move, but be conscientious, be aware of what your body's doing and how it's feeling. And then if you are obviously in that red zone, 8 beyond, that's okay, we need to put the brakes on it. We need to discuss it, see what's going on and why your pain is so high and limiting what you're doing. So that's an internal guide, like that's a guideline from a pain scale. From our aspect, obviously, we're looking at quality of movement. We're seeing, are you compensating? Are you able to do what we're asking you to do? And how your body is recovering. There's this great visual about pain and function or activity. If your pain stays like this, but your capacity goes like that, that's progress, right? But if you're never tracking what you're doing in your capacity levels, you will always focus on the high emotional impact, which will always be pain. Your pain will always bias you because it's so intimate and it's so close to you, right? It will always overshadow what you're doing unless you're tracking the activities you're doing while experiencing this pain, right? So if your pain stays fairly consistent, but your activity level is increasing, that's progress. And that means you can still continue to do what you're doing.
So Gene,
yeah.
should you in a PT setting, should pain increase, should discomfort increase during PT?
Yes and no. I think it's again, it's qualifying discomfort, right? It's when you've been in pain for a while, your brain has a hard time processing sensations. So for somebody that wasn't in pain that doesn't exercise, they might feel muscle soreness. They might feel that that burning sensation, right, from your muscles that when you exercise a while. Somebody that has been in pain for prolonged periods, they might have the same sensation happening from a biological standpoint, but their brain's interpretation of it is this is danger. Yes, the muscles are burning, but I feel discomfort. Therefore, you shouldn't do it. So should you feel it? Sometimes, yes, you should. But as long as it's in those kind of in that wheelhouse of those numbers and the quality is there, then it's okay.
So that gets to another question then that's been asked kind of frequently on the forums and that was sent to me, which is what are the do's and don'ts regarding PT exercises? So what exercises should you really avoid, especially in this disease where it's based off of some component of inflammation, and which ones are wise to do?
Good question. Good question. Poorly worded, because it again goes to the vilifications of good and bad, right? This I know it's hard, and you want to qualify that because obviously something that is dangerous has to be bad, right? So there is no PT exercises. There's no such thing, right? There's no such thing as physical therapy exercises. It doesn't, there's exercises, there's movements, and again, movements with purpose, movements within structure is exercise. So what exercise further progress your goal? So that's how I would phrase that, right? Which exercises will further progress the goal that you're trying to attain? It depends on what stage you're at. So if you're post-surgical, right? If you just had surgery and you're dealing with your tissue has to recover and it has to heal up. You're going to be in windows of tissue healing. So this is where working with a clinician is very important, because we understand the phases of tissue healing and when to push during each stage and how to push during each stage. If there is no if there's no medical procedure, if you're just in pain and you're at the stage of progressing, right? If you have pain, if you had surgery, everything's healed up and you're cleared, and it's about progress now. Then it's about understanding movement patterns and planes of movement. So we live in a three-dimensional space, and we move mostly in three planes: sagittal plane, forward and back; frontal plane, left and right; and then transverse plane, rotational. So before I would have anybody do specific exercises, I would look at gross movements through those planes, right? How well do you move overall through these big movements? What activities, what movements will you be doing in everyday life that regardless whether you're with me or not, you have to do no matter what? And then we need to see the quality of those movements. Most of us spend so much time in this forward and back movement that we forget that we have this one and this one. I mean, most of you, when's the last time you completely rotated one way or the other?
Before surgeries.
Yeah, but by the look on your face is probably not that often. And we're asked to do something like that. But let's say you are driving in the car and you have to get a seatbelt and you're doing this, and the seatbelt's not in the same place where it was before. Or you're driving somewhere and you have a child or grandchild behind you and they drop something and you have to reach back and do that when you don't usually do that. Is that exercise? Is that a dangerous movement? Does that hurt? Yeah, if you haven't done it in a while. If you have to reach for something in the top of your cupboard and you haven't reached for there in a while, and you reach up, all of a sudden you stretch a little bit further and you're like, oh, why did my shoulder all of a sudden cramp up or feel that? It's because you haven't done that. So to answer that question, it's understanding those movements first. Gross movement patterns are very important. Let's see how you move in each one of those movement planes, joint by joint, or even just bigger movements. And then we can structure exercises to progress from there.
Lauren, I think your mic is muted. I saw the mouth moving.
It was, and I have a dog sitting on my foot, so it's kind of a little hard sometimes. So there's a really good question that came in that there is a dog sitting on my foot. So somebody would like to know, are there exercises or movement that can decrease swelling?
That's a good question. There are. One, first understand where in the inflammatory process you are and why the swelling is happening. So if it's swelling due to post-surgical, or if it's swelling due to an acute injury, you're going to go through somewhere in the 7 to 21 day inflammatory process, at which point swelling is normal, right? That you have to expect it and normalize it. Say this is okay, this is normal. Sometimes longer than that, because you have kind of micro inflammatory processes. Sometimes the best thing, actually often the best thing for swelling is holding it above heart level. So letting gravity be your friend and pulling those fluids back. Too often, obviously, we say to elevate, but most people don't realize elevation has to happen above the heart. So if you're sitting here and you prop your leg up and the leg is still below your heart level, yes, the leg is elevated, but it's not elevated above your heart. So you need to have this gradient down. And so elevation, but then elevation with a pump action. So if, let's say it's your wrist, right? If you elevate your wrist above your heart and you're laying down, creating a gentle pump by bending your hand and then bending your hand and wrist, and then bending your hand and wrist and elbow, creates this pump action, using your muscles as a pump to push that fluid down. So it's very simple. These are not complex things to utilize. One, it's understand why the swelling's there, what stage of healing it's in. If it's obviously, if it just swelled up on you out of nowhere, that's a very different story. But if you're going through the inflammatory process, it's going to happen no matter what along that timetable. Elevation, and then creating that muscle pump gradient to help the fluid back towards the heart.
I have a question.
Sure.
I'm 14 months post-op, and the physical therapy when I was in the hospital, of course, and then the rehab center, and then at home, and even going to physical therapy, I barely had anything done because every one of the PTs were too afraid to even do anything with me because they had never run across this before. So even today, I have still not had a lot of physical therapy. I live on fentanyl from my pain, but I don't know if like building up the muscles, because they were only able to remove half of my tumor in the ischium, so I can feel it in there every time I take a step. Is there something that I can do to build up muscle? If I build up muscles in there, would that help? Or do I need to really start searching for somebody else?
That's that's probably equal parts frustrating and challenging. It's hard when you constantly feel it there, right? That there's no real escape. And I think it's if we work through kind of setting the goal. So let me ask you, what would you want your goal to be?
One of my real goals is I would like to be able to sit on the floor and play with my granddaughter.
That's a great goal. I love that
Not
goal.
get on the floor.
I love that goal. When is the last time you've been able to get on the floor?
I'm going to say about 2 years.
Okay. So to me, that is our structure that we're working with, right?
Mhm.
We're saying the goal is to get down to the ground and then get up from the ground, right?
Right.
That's the goal. Now, all the other questions you asked me are part of it, but they're also kind of irrelevant in that, does muscle building help? Do these specific tissue aspects, are they important? They're part of the process. But the most important thing is getting down to the ground and getting up, and then everything we have to do to make that happen. So if you are working with us, obviously what we would do is start breaking down the motion of that. We would say, what do you expect to feel as that happens, right? Talk us through what pain you expect to happen, and how you expect it to affect you.
If I were to try and get on the ground, I already did. I dropped something on the floor and I was feeling pretty good at that time. So I get on the floor and pick that up because I was by myself in the house, which I should have never done because it took a lot of strength, a lot of frustration, a lot of tears to get myself back up off that floor. It was very, very painful.
Correct. So the question still stands, right? You don't have to answer it now. It's a very personal thing. I understand, but we would ask again, even if you did it, if you were going to do it again, what would you expect to feel? What pain would you expect? And we would work through that, right? We would work through that challenge of it. Most times we don't do something because of our fear of what would happen. So if we discuss it, if we bring it out from here out through here, then it's everyone's to discuss and work through.
It would be comparable to having a pebble in between your bones. That's what it feels like. It feels like there's something in between my bones, and every time I move it the wrong way, it shifts the wrong way, and it feels like it's chipping away at my bones.
Good. And do you think that's going to change? Do you think that's going to go away?
Not unless they get rid of the tumor, and I can't have any more surgeries, they said.
So that's our constant, right? We know that is going to be there, and yes, we accept that and we normalize that as part of treatment, right? Our goal is not going to be to reduce the sensation of the pebble in the pelvis, right? We know that that's going to be there. Our goal will be to say, okay, let's create a range of tolerable discomfort with that pebble, and now let's break down the steps we would have to create for you to be able to get down to the ground and then get back up, and make each one of those steps an exercise. And then we would create your structure around that. Here's how many repetitions we're going to be doing. Here's how long we're going to be doing it for. Here's how we're going to make it safe for you, right? How you don't have to fear that you can't get back up.
Well, I should probably return to physical therapy and see if there's anything they can do now, if they're not too afraid anymore.
To the right physical therapist.
Yeah.
Yes. Right. You have to do some interviewing. You have to be your I'm sure, I don't know, I have to tell you guys this, but you have to be your own advocate.
Right. Okay.
Right? Call around and say, hey, I have this condition. I don't expect you to know everything about this condition, right? That's not why I'm calling you. I want to get down to the ground. I have this feeling. I'm not coming to you for pain. Yes, I want to be monitoring that pain. I'm coming to you because I would like this goal and this function to be better. If their response is, what insurance do you have? And we only treat pain, then your answer is, you're not the place for me. Right. If their question is, tell me more about your goal and how you want this to go, then continue with them, right? But stick to that goal. And then it's your physical therapist's job to say, okay, here are the muscle groups, here are the movement patterns, here's how all of them play together to create this, for you to accomplish this goal, and then for you to grow and for you to develop it further, so you don't need us anymore, to be able to get down on the ground, play with your grandkids. If you slip, God forbid, slip and fall, to be able to get back up by yourself, right? So there's a spectrum of needs for getting down to the ground and back up. There's a great study about morbidity and mortality, that one of the signs of longevity of life is the ability to stand up off the ground without using your hands, and how quickly you can do that. So that's a very important goal that we're always big fans of helping people down to the ground and back up again.
Thank you.
Yeah, absolutely.
Thanks. So Patty also had another question, and she has PVNS in the knee, or TGCT as commonly some of us know it. So she has it in the knee, and she has not had surgery for it. But she had a knee replacement about 20 months ago, unrelated. And so she works out with a trainer twice a week and attends these classes. Should she be icing her knee after workouts to reduce the inflammation? And I know someone else asked about the use of like NSAIDs as well. How do you see those cooperating into your regimens?
Ice and heat are analgesic, meaning they are sensory pain modulation. They will not in any way, shape, or form, superficial ice, change any of the deeper tissues. It just doesn't happen. What changes the most is skin temperature, and it doesn't really travel deeper down than that. So our recommendation is always, if somebody asks, should I use heat or ice? The answer is, if it feels better and you like how it feels, then go for it. Early on, best practices is not to use it, because you want the inflammatory process to happen and run its course. Later on, if she's in kind of that development or post acute stage, then it's the tolerance and if it feels good. NSAIDs, that's a slightly different story. If you have to continually take NSAIDs after training, I think a bigger question is why, not whether you should take NSAIDs, why that keeps happening. But also, that goes into your gut health, and because NSAIDs, prolonged NSAID use has been shown to affect the inside lining of your stomach. So it depends if you're taking other medications. It depends if you have a history of blood disorders. So that's a tough one to answer. My question is always, again, if somebody asks me, should I keep taking NSAIDs? It's what is going on in your training that is requiring you to take NSAIDs, because we never train anybody and never come to us, aside from some occasional scenarios where they go, wow, I really needed to take some Advil after that workout. That usually means that we messed up somehow in our programming.
So there was another great question that came in through the TGCT website, and it's basically, how is it possible to lose weight without using my knee, hip, or ankle?
Well, if pain was $1 million question, this is the $1 trillion question. Weight loss is it's it's also complex. You have to understand your macronutrients for weight loss. So before getting to movement, you have to understand how many calories you're consuming in a day. You have to understand how many grams of protein you're consuming in a day. Are the two main before you be getting even deeper. Most people, I mean, truly most people have a poor understanding of how many calories they consume in a day. There is a very big difference between I think and what is. And the answer I get most often is, well, I eat healthy. Well, I eat pretty good, or I eat, a healthy regimen every day. And my response is, that's great, but I'm not asking you whether you eat healthy or not. I'm asking you how many calories you're consuming in a day. Because ultimately it is a fairly simple formula for most people. Now, again, the caveat being that there's always exceptions. There's always thyroid issues, and there's other hormonal issues. But we're talking most commonly is, if you don't know how many calories you are consuming in a day, weight loss becomes a guessing game. Movement is important for weight loss, absolutely, but it is still secondary to nutrition and understanding calories that you're putting in. The second piece is protein. If most people don't know how many calories they're consuming in a day, even more people have no idea how much protein they're consuming or how much protein they should consume. So if you're trying to build muscle and you're being active, most people need to be consuming some range of 1 to 2 times their body weight in kilograms. So most people should be, depending on how much you weigh, again, but it could be anywhere from like 120 to 200 plus grams of protein a day. So if you start tracking what you're eating in a day and you start adding those numbers, I think you'll be pretty surprised. But ultimately, weight loss is, less calories out than calories in. And you can't do that unless you start tracking calories. So start with that, starting track the calories, how many calories you're eating in a day. Then it's see how much protein you're putting in your body, because you need protein to build muscles, and you need proteins to sustain you as you're doing training. And then the next best thing is walking, right? Understand your calories, understand your protein, and start building up your walking tolerance for distance. If you start walking, it should be about 3 miles per hour. If you can build up your walking speed at 3 miles per hour, um, one, that's good for your health, but two, that's a great way to begin a weight loss journey.
Thank you. That was a great answer to that. And then another scenario, and this one you'll like because it has actual like movement measurements. And so this patient had said post-op, she did their physio for 6 months, and mainly to strengthen her thighs and increase range of motion, which was at 0 degrees straight and then 30 degrees bend, or 130 degrees bend. And then, however, though, her physio or her PT doesn't know anything about the disease. So is there any specific ways she can increase her bending further that may be specific to an inflammatory response or a disease like a tumor disease?
That's I don't know. I don't know that, because that's so individual based, based on how she's presenting. Um, the PT doesn't really need to know the specific condition to be able to help with something like that. Um, More importantly, any clinician should be able to research and figure out what the person has and the latest evidence on it. You know,
Hopefully.
no, not hopefully, definitely. That there is no hopefully there. They don't get a pass on that. I'm all for solidarity in the profession and looking out for my colleagues, but they don't get a pass. Nobody gets a pass for being lazy. And research is something that we have to be always looking at, because we can't know everything. But we definitely, I mean, we get taught how to read research and analyze research in school, and we have to do that to maintain modern practice. So you could always be an advocate for yourself, right? Bring the research, say, here's the latest research, please read it. Like if you like your clinician, but you feel like they're just not digging into the research. Um, but range of motion is tough. It's tough without knowing the specific limitations and kind of what's going on. Was it a her? You say it was a her? Or
I think so. I'm not sure. That's
with
bad to assume, but I assumed.
with them, what's going on with them?
Do you have any last remarks or any take-home messages for our specific community that's plagued with chronic pain and swelling and PT forever?
I wish I had something super motivational and encouraging. The biggest thing I'll say is that there's always a path. There is a movement. There is a movement for all. I promise you that. Um, I've seen so many cases and of people being told they can't do X, Y, and Z, or they will never do X, Y, and Z. Ultimately, that stems from we haven't done it before, or you do not fit into our mold of practice because you require a little bit more work, or we will not get paid for this with our insurance companies because this is not a very easy paperwork. And then I hate saying that, and it's not always the case, but largely when you're dealing with challenging medical scenarios, there's so much complexity that goes into within our healthcare system. But our bodies are so robust and adaptable. And yes, timing might be longer, and there will be certainly ups and downs. That's a certainty. But there is a movement. There's a movement and a path for most, if not all, challenges. It's just being persistent and patient with it.
So I'm going to contact you to learn how to run again, right?
I cannot wait to start you training for running. It's gonna
Okay,
be
well,
great.
Thank
I
you.
was actually just gonna ask the same thing. Yeah.
Yeah, if you want to provide also any contact information so people can give any questions, if you want to put that in the chat, people can send you questions, or they can email me and I can forward it as well, whichever you prefer.
Yep, I'll write my email in the chat. Don't hesitate, shoot me emails. I'm happy to give suggestions and guidance where to look. Obviously, I can't give specific medical advice without treating you guys. But I'm
Maybe you can
certainly
even
happy to-
refer, because you have a network, right? You can even
Yeah.
refer people.
Oh, for sure.
Well, thank you everybody for attending. And on May 20th at 4 p.m. Eastern Standard Time, we're going to have a bunch of experts come in. Dr. Taps from MSK and Dr. Moeller from UCLA. And they're going to give more comprehensive on surgery as well as like pharmacological treatments and get more deeper into like the progression of our disease as well. And so please stay tuned. I'm sure you'll hear all about it in every group possible because I make my rounds for sure. And thank you all for coming. Yeah, and if you have any questions, please feel free to reach out to me or Gene, because I'm not going to say his last name.
Even though you can now.
Yes, it kind of.
Well, I'm not going to get you training for running until you learn how to say it perfectly.
Yeah, thank you, everybody.
Thanks for having me.